Major depressive disorder. This is the form most people picture when they hear the word depression. It involves a period of at least 2 weeks where a person feels persistently low, loses interest in things they once enjoyed, and struggles with sleep, appetite, or energy. Doctors first began separating it from ordinary sadness in the late 19th century, when researchers noticed that some emotional low points did not fade with time or circumstance the way grief usually does. What sets it apart is its intensity and its grip on daily functioning. Someone with this condition may find it hard to get out of bed, concentrate at work, or feel pleasure in anything, even activities that once felt effortless. Physical symptoms often show up too, including unexplained aches, digestive trouble, or a persistent feeling of heaviness in the chest. Thoughts can turn dark, sometimes drifting toward feelings of worthlessness or thoughts of death, which is why clinicians treat this diagnosis with particular seriousness. Treatment usually combines therapy, most often cognitive behavioral therapy, with antidepressant medications such as SSRIs. The response varies widely from person to person. It can appear after a single triggering event or emerge with no clear cause at all, which is part of what makes it so difficult to predict. Persistent depressive disorder. Formerly known as dysthymia, this type is defined less by severity and more by duration. A person may experience a low mood that lingers for 2 years or longer, often at a level mild enough that friends and family barely notice anything is wrong. That quiet persistence is exactly what makes it dangerous. Because the symptoms rarely reach crisis levels, many people live with it for years before ever seeking help, assuming their low energy or flat outlook is simply part of their personality. Common features include low self-esteem, poor concentration, and a general sense of hopelessness that colors everything without ever spiking into a full crisis. Some people with this condition also experience what clinicians call double depression, where a major depressive episode temporarily stacks on top of the ongoing low mood, making an already difficult baseline even harder to bear. Unlike major depression, which can arrive in a defined episode, this type settles in gradually and becomes the emotional background of someone's life, often stretching back to adolescence before it is ever properly identified. Bipolar depression. This type occurs as one half of bipolar disorder, alternating with periods of mania or hypomania, where mood, energy, and activity levels rise sharply. The depressive phase can look almost identical to major depressive disorder from the outside, but the presence of those opposite high phases changes both the diagnosis and the treatment approach entirely. Mood stabilizers, rather than standard antidepressants alone, are often needed because antidepressants can sometimes trigger a manic episode in someone with this condition. There are actually 2 recognized forms: bipolar 1, marked by full manic episodes, and bipolar 2, marked by milder hypomanic episodes paired with deeper depressive lows. Diagnosis can take years, since people often seek help during the depressive phase and never mention the high periods, which can feel productive or even pleasant rather than problematic. Historically, the highs and lows of bipolar disorder were once grouped under the vague term manic depression, a label that captured the swing but missed the complexity of what patients actually experience. Postpartum depression. This type develops in the weeks or months following childbirth, driven by a combination of hormonal shifts, sleep deprivation, and the enormous adjustment of caring for a newborn. It goes beyond the so-called baby blues, which usually fade within 2 weeks, by lasting longer and cutting deeper into a parent's ability to function or bond with their child. Symptoms can include intense guilt, fear of being alone with the baby, or intrusive thoughts that frighten the parent experiencing them, even though such thoughts rarely translate into actual harm. For much of history, this condition was dismissed or hidden, often mistaken for simple exhaustion or attributed to a mother's supposed lack of resilience. Modern research has shown it is rooted in real biological changes, particularly the sharp drop in estrogen and progesterone after delivery, alongside the physical strain of recovery and disrupted sleep. It can affect fathers and adoptive parents as well, though less commonly, since the emotional and lifestyle upheaval of new parenthood is not limited to the person who gave birth. Screening for this condition has become more routine in pediatric and obstetric visits over the past 2 decades, helping catch cases that once went unnoticed. Seasonal affective disorder. This type follows a distinct pattern, appearing during specific seasons, most often the darker months of fall and winter, and lifting again as daylight returns in spring. Reduced sunlight is believed to disrupt the body's internal clock and lower serotonin production, while also increasing melatonin in ways that leave people feeling sluggish and prone to oversleeping. It was formally identified in the early 1980s by researchers studying why some people experienced a reliable dip in mood every year at the same time. The condition is far more common in regions farther from the equator, where winter daylight hours shrink dramatically, and it tends to affect women more often than men. Light therapy, using a specialized bright lamp each morning, has become one of the most effective treatments, directly addressing the light deficiency believed to drive the symptoms. A rarer summer pattern version also exists, where heat and long daylight hours trigger symptoms instead, though it is far less common and less understood. Atypical depression. Despite its name, this is actually one of the more common forms of depression, distinguished by a set of symptoms that run opposite to the classic pattern. Instead of losing their appetite, people with this type often eat more and gain weight. Instead of insomnia, they may sleep excessively, sometimes 10 hours or more a night without feeling rested. A defining feature is mood reactivity, meaning their outlook can briefly brighten in response to positive events, something rarely seen in major depressive disorder, which can make the condition confusing to friends who assume the person must not be struggling that much. This type also tends to bring a heavy, leaden feeling in the arms and legs, along with a strong sensitivity to rejection that can strain relationships and make social situations feel exhausting. Because the symptom pattern differs so much from textbook depression, it was historically underdiagnosed, and certain older classes of antidepressants, particularly MAOIs, have shown to be especially effective for this specific type. Psychotic depression. This type combines the emotional weight of severe depression with a break from shared reality, involving hallucinations or delusions that usually align with the person's dark mood. Someone might become convinced they are responsible for a tragedy they had no part in, or hear voices reinforcing feelings of worthlessness. Because it blends mood symptoms with psychotic features, treatment typically requires a combination of antidepressant and antipsychotic medication, and hospitalization is sometimes necessary to ensure safety. It remains one of the more severe and less commonly discussed forms, partly because the psychotic symptoms can be mistaken for schizophrenia if a clinician does not look closely at the underlying mood disturbance. Premenstrual dysphoric disorder. This type is tied closely to the menstrual cycle, emerging in the week or two before menstruation and easing shortly after it begins. It goes well beyond typical premenstrual symptoms, bringing intense irritability, hopelessness, and anxiety that can disrupt work and relationships during that window each month. Researchers believe it stems from an unusual sensitivity to normal hormonal fluctuations rather than from abnormal hormone levels themselves. It was only formally recognized as a distinct diagnosis in psychiatric manuals in 2013, after decades of women's cyclical mood symptoms being minimized or overlooked entirely. Situational depression. Also known as adjustment disorder with depressed mood, this type arises directly in response to a specific stressful event, such as a job loss, divorce, or the death of a loved one. Unlike major depression, its symptoms are closely tied to that triggering circumstance and tend to ease as the person adapts or as time passes. The line between this and clinical depression can blur, though, especially if the emotional response is disproportionate to the event or lingers far longer than expected. Therapists often watch this transition closely, since what begins as a normal reaction to hardship can sometimes deepen into a more persistent depressive disorder if left unaddressed.